local committee for inviting me to this meeting that allow me to be here for my first time, and also allow me to know a little bit more about your society. And also I would like to thank you all the people are in the room that are sitting in there since 8:30 in this morning. So thank you very much for remaining there. So without further delay, I will start with my presentation. This is the potential conflict of interest. My topic is the infectious complications, the best of the EBMT 2022. As you can see, this is the numbers of the abstracts in between 2018 and 2022. We have 36 topics. And for this year, we have more than 4,000 abstracts. As you can see, the median is 833, and 5 topics of these 36 represent 41% of all the abstracts. Are in orange, as you can see, graft-versus-host disease, clinical, infectious complications, non-infectious complications, pediatric uses, and acute leukemia. Here you have the numbers of each meeting. As you can see, more or less 1,000 per year, except 2021. That was an atypical meeting due to several things. First, have the impact of the COVID pandemic, and second, have a short time between the previous one to this one. As you can see, the infectious complications is the second most popular topic of all these 5. And it varies from the first place in 2022 to the 3rd place. So infectious complications are a very popular topic, and many people send abstract to the Congress. So why is important infectious complication? Why the people are sending many communication in the meetings? The reason is on this slide. If you improve the management of infection of your patient will live more. And this is interesting a study of EBMT with, you can see more than 100,000. Yeah, with more than 100,000 transplant patients, allogeneic, in first transplant. As you can see, divided by a period of 5 years, the overall survival increase, and this is due to the decrease in no-relapse mortality. As you can see, there was no decrease in relapse except in courts, but that is due to the better selection of the candidates more than other things. And here you have the most frequent causes of no-relapse mortality are GVHD and infection. It's curious to see that depending on the type of donor you have, the first cause of death is GVHD or infection. I'm not going in detail, but also you have to know that the majority of the patients that are dying due to GVHD die due to infection. So infection at the end is the main cause of death of these patients. So here's a summary of all the infectious complication abstracts sent into the 2022 Congress. As you can see, the virus was the most frequent topic. More than 70% of all the abstracts are related to virus. A few are related to bacteria, and even fewer to fungi. As you can see, SARS-CoV-2 represents more than 50% of all the abstracts sent to the Congress. CMV was the second. It's a classic pathogen. So as you can imagine, if I have to review all the SARS-CoV-2 communications, this presentation will focus on SARS-CoV-2, and maybe we are a little bit tired of SARS-CoV-2 after 2 years of pandemic, so I decided to focus on non-SARS-CoV-2 complications. So let's start. The slide is a little bit bad in the screen. Let us start with this poster. Is the EBV post-transplant lymphoproliferative disease that fails to rituximab. This is an interesting study. And the background is that you know the EBV PTLD is a complication that has a great mortality that nevertheless has decreased over time. As you can see, before 2000, it was 85%, and after 2013 was 30%. So this was due to the preemptive or targeted therapy with rituximab. This is quite similar our management of CMV. And this study is a retrospective study at 29 centers across America and European Union of EBV PTLD patients following allogenic stem cell transplantation who received rituximab or rituximab plus chemotherapy between January 2000 and December 2018 and were refractory. So this is a very specific population with EBV PTLD. As you can see, 81 patients was included. The median age 48 years. The majority of those was unrelated, matched or mismatched, and there was also a great proportion of cohorts, 25%. The median time from to transplant to PTLD was 3 months. This is the usual time. You know that this complication is an early complication. The median time is more or less 3 times after the transplant. And here you have the results. It's terrible. 91% of the patients die. 70% related to the PTLD. And the median overall survival is less than 1 month. So if you have a patient with EBV PTLD is refractory to rituximab, the survival of this patient is dismal. So what we can do? So we have here today a lot about cell therapy in the form of CAR-T for lymphoma, myeloma, leukemia. But also, as you can going to see, cell therapy has come to stay with us, not only for neoplastic disease, but also for infectious complications. And this study will show why. As I've said, those patients who have EBV PTLD refractory to rituximab have a dismal outcome, less than 1 month overall survival. So what we can do? So this is a phase 3 multicentric American study of this product, tabelecleucel, is difficult to pronounce, for the treatment of these cases of EBV PTLD refractory to rituximab. And this product is an investigational off-the-shelf allogeneic EBV-specific T cells immunotherapy. Here you can see how is the product obtained. They are obtained by apheresis for unrelated donor, nothing to have with the patient or the donor of the transplant, is absolutely independent of that. You separate the lymphocyte B, transform with EBV, and stimulate the same in the same donor, the T cells, and you selected them, you cryopreserve it, and they are ready to use based on HLA match with the patient that need it. Here is the type of a study. This is a phase 3 with only one arm. I think I missed something. Here, yes. There was 38 patients, 14 after hematopoietic stem cell transplant patients, and 24 after a solid organ transplant. The median age nearly 33 years. And as you can see, 3/4 of the patients have extranodal disease, a high-risk characteristic. Here is the design of the study. The patients with hematopoietic transplant that fails to rituximab can go to the study, and the solid organ can go into 2 groups, one that fails to rituximab, another group that fails to rituximab plus chemotherapy. The patients will receive an infusion of this product, and every 35 days, if they don't meet the end of the treatment criteria, will receive another, and then they'll fill the end criteria for stopping the study. And the primary endpoint was the response rate by the independent review committee. Here you have the results, impressive. 50% of response, exactly the same in solid organ and hematopoietic transplant. The median number of cycles was similar. The median time to response is quite fast, 1.1 months. And the estimated median overall survival is for all the population more than 18 months. It is not estimable in this group because they don't achieve 50% of, more than 50% survival. So at the conclusion, I think this is one of the most interesting presentations that we have in the last EBMT meeting. This product is it shows the data in this phase 3 for the treatment of EBP PTLD refractory to rituximab, offers a high rate of response, 50%, with a fast time to response, 1.1 months. This is very important. And the most important finding was the overall survival was quite long, 8 months. You remember from the previous study was less than 1 month. So it was well tolerated, no evidence of cytokine release syndrome, GVHD, organ reaction, infusion reactions. And these results represent a real opportunity for this patient when they fail rituximab. So remember, their T-cell therapy is not only for neoplastic disease, but also for infection complications. So let's go to CMV. CMV is a classical virus in allogeneic transplant patients, as you know. Until 2018, the strategy of choice for managing this patient was the preventive therapy. But something happened in 2018. There was the approval of letermovir. This was in the European Union, in the FDA was in 2017. But in Europe, it's not, the approval, the central approval don't mean that all the countries can start using the drug at the same time. And here you have some examples of 4 countries that started quite late after January 2018. And this survey was sent to all the transplant teams. The response rate was 31%, 180 centers, is quite good. And I'm only going to present what is a historic change. Is the use of prophylaxis. As you can see, letermovir was used in the 61% of the centers that use prophylaxis, and in the centers that are adults, it's 34%. You know that the letermovir is not approved for pediatric patients. And this you have to take into account that many countries has no access to this drug. So this is really an historic change. We moved from preemptive therapy to preemptive therapy plus letermovir as the best prophylactic and strategy to prevent complications in allogeneic stem cell transplantation. So continue with CMV. This is an interesting study about maribavir. Maribavir, for refractory CMV infection after transplant, solid organ or hematopoietic transplant. And in here, the background is that those patients that have infections that are refractory to the standard treatment, we have limited options that are limited mainly by toxicity, hematologic or renal. Maribavir have shown in a randomized trial, you have here the reference, to be more effective and safe than other options. And what they present here is the primary endpoint analyzed by the basal line of renal impairment. All the patients that have different renal function have the same efficacy as patients with normal functions. That is the question that I'd like to answer this study. This is a randomized study, 2-to-1, when the patient have a refractory CMV infection, can randomize to maribavir or the investigator-assigned therapy, and the endpoint is the viremia at 8 weeks. Here you have the results. Compared to normal renal function, those who have mild or moderate renal deterioration have the same response rate as those without any renal dysfunction, and this was statistically significant. But those who have severe renal impairment, the numbers are quite low. There's a big difference between letermovir that clears the virus much more than those with a standard treatment, but due to the lower numbers, it's not statistically significant. So in this post hoc analysis, a great proportion of patients on maribavir achieve CMA clearance at 8 weeks in renal impairment categories. That is important. If your patient have a renal deterioration, he or she will respond equally to this drug if they have a CMV refractory infection. This is important. This is another study about the same study that analyzed, in this case, the safety of stem cell transplant patients. You remember that the group combined solid organs and stem cell. So here is presented the data about 141 allogeneic patients. The schedule of the protocol is the same as I commented before, and here you have the results. Maribavir had a good safety profile. You know, neutropenia, hypokalemia was more frequent with the other type of treatments, and the only adverse event that was more frequent with maribavir is the alteration of the taste. That is really not very important. It's important, but it's not very severe, and it is quite useful because you know if the patient is taking or not the medication. Nearly all the patients that take the medication refer some taste disturbance. So, good news that maribavir is, as you know, is licensed in the FDA, not in the EMA. It's a good choice for those who had a refractory infection. Changes the virus. This is the human metapneumovirus infection in allogeneic stem cell transplant patients. Here also appears the name of the first and the last authors. So sorry for you can see it, but here was the name of the first and the last authors. The background is, as you know, there are many respiratory viruses that affect our patients, including the SARS-CoV-2, of course. And this virus was discovered quite recently in 2001, and is a seasonal virus like the influenza. There are few studies in allogeneic stem cell patients. The progression to lower respiratory tract disease is quite high, between 15 and 60%, and the mortality for those who have a lower respiratory tract disease is quite high, between 10 and 40. Even less data exists about the ribavirin treatment of these cases. Counting all the published cases in allogeneic transplant patients, there are less than 200 patients. So here I present this retrospective study of the EBMT. That include all consecutive allogeneic transplant patients that have diagnosed of metapneumovirus by PCR from January 2012 to January 2019. You can see there's a large number of patients, 428. Children was 6.5%. And the median follow-up is more than 3.5 years. As the first evidence is that the virus in transplant is exactly the same as in the general population. It shows this seasonality. Yeah? It's exactly the same, like influenza. And here you have the mortality. Those patients who have upper respiratory tract disease have a very good overall survival. Those who have lower tract disease have a lower survival, lower even if it's proven they have the virus in the BIL. So this virus is important in transplant patients, have high mortality in those with lower tract respiratory disease. And this I am going to the SARS-CoV-2 topic. I'm going to present 3 studies. This is, as you know, the COVID in transplant patients have a high mortality between 20 and 40%. And the question that I'd like to answer this study is, does vaccination impact the outcome of COVID in this patient population? So, as you know, the EBMT have a registry that prospectively are including all the patients who has SARS-CoV-2 infection or disease. And also we look how many of those have a vaccination with infection or COVID after vaccination. And we look what were the outcome. We find 32 patients, 24 allogenic, 6 auto, and 2 CAR T-cell patients. And you can see that even that there is not significant, because the numbers are quite small, that the patient have 2 doses of vaccine, and more than 40 days after the second dose, the survival was quite high, and none of them goes to the intensive care unit. You have less than 2 or 2 with less than 14 days after the vaccination, you get the infection, you have a higher mortality and also a higher requirement of intensive care unit. So this data suggests that those patients that are completely vaccinated, at least with 2 doses, are protective to the more severe forms of SARS-CoV-2. That is important observation. Yes, I don't know if you can see here is T-cell therapy for SARS-CoV-2 infection. So as I showed, the major mortality in transplant patients is high. So improving therapy is an unmet need in this patient population. So the specific T-cells are interesting area. Yeah, we have seen that for EBV was probably the solution now. So what are moving in this area for SARS-CoV-2? I summarized 2 posters. There are 2 laboratory posters. The first one shows that it's possible to expand in both COVID patients recovered from COVID and unexposed patients these specific T-cells against SARS-CoV-2 with reduced alloreactivity. That is good. And this opened the possibility to use these cells as treatment of these patients. And the second poster is an in vitro test that shows that these cells have quite a few alloreactivity and also support that they can be used maybe in the treatment of these patients. So there are 2 laboratory studies, but I think it's quite interesting. It opens the door to use these specific T-cells in the treatment of COVID. This is, I think, the last study about virus. This is posoleucel. This is a multi-specific T-cells product therapy for the prevention of complications in allogeneic stem cell transplant patients. You know that many viruses affect our patients. The most important are shown in the slide. And these, their specific T-cells have been shown in other studies that can prevent the treatment can improve the course or prevent infection. So what they do in this multicentric phase 2 study is the prevention of clinical significant viral infection with this posoleucel. This is allogeneic off-the-shelf investigational T-cell that targets the 6 viruses more frequent after allogeneic transplant: adenovirus, BK, CMV, EBV, herpes 6, and GHCV. So this is an interesting approach that they here select 26 high-risk patients that in theory are at high risk to develop some of these infections, and they use these cells prophylactically. Here is the summary how they produce. This, at the end, they cryopreserve the cells, and they are using after the transplant from unrelated donors. Here you see the structure of the protocol, and they use one infusion every 14 days up to 7 doses. And the primary endpoint was at week 14, the number of new clinical significant viral infection. Here you have the patients included, 26. The median of first dose, 42 days after transplant. The median of doses was 7, and 24 of 26 was evaluable at 14 weeks. Here you have the safety result and the efficacy. The acute GVHD was 23. Remember that this is a prophylactic strategy, and this is lower than reported for this population. It's in the range of 35 to 50%. And the discontinuation due to adverse events was quite low. And about the efficacy, there were 2 clinical significant infections, was CMV replication that was treated, and 1 end organ disease that was EBV PTLD. And the interesting also aspect is that these cells persist long time after the infusion. As you can see, even at week 19, you can detect these cells in 80% of the patients. And jumping to bacterial infection, this is the only abstract that I'm going to comment about bacterial. You know that 2 minutes, yes. You know that antibacterial prophylaxis is a very controversial topic, and this study looks in a cohort, sequential cohort, if the stopping of levofloxacin prophylaxis is safe, and the answer is yes. Even they have a great incidence of gram-negative bacteremia. The mortality-related infection was exactly the same. So it's safe to stop levofloxacin prophylaxis in these patient populations. And this is 2 slides. I'm going to comment nothing about it. Other session dedicated to infection complications that you can see the video in the app of the EBMT. And that's all. Thank you for your attention.